Hello, everyone. Thank you for joining in today. We are here to present our project on Grady Health Coaching. As an overview, goal oriented health coaching is an effective technique for improving health behaviors in patients with chronic diseases, especially patients in underserved communities. One specific technique is motivational interviewing, which is an evidence based technique that uses a collaborative, patient centered approach to counsel patients in changing behaviors. Grady Health Coaches is a program that utilizes motivational interviewing coaching by medical students to support Grady patients in achieving their health goals.
Through Grady Health Coaching, first and second year medical students are paired with primary care patients that have been identified by their provider as needing additional support outside of the clinic. Prior to working with patients, students are trained in motivational interviewing through didactic and interactive sessions. They then call their patients 2 times a month to work on patient-identified goals. Additionally, throughout the year, first and second year students have the support of third and fourth year mentors who can help teach them more specifics of motivational interviewing and who also upload patient documentation to the chart.
So this year we had 19 patients participate in the program, each of whom were managing a variety of different chronic conditions, the most common being hypertension, followed by diabetes, exercise, and obesity management. These 19 patients were matched with 19 student coaches who participated in motivational interviewing, helping them refine their general health goals into actionable steps, such as keeping track of their glucose, scheduling therapy, attending exercise classes, and more. So supported by their health coaches, the patients this year made progress towards their overall health goals.
Students and health coaches completed pre- and post-program surveys throughout the program to measure areas of growth. Surveys from 2022 to 2024 showed that after participating in the program, students demonstrated increased confidence with using motivational interviewing skills and addressing social determinants of health. One quote said, "I learned how important it is to take time to reflect with patients and encourage them, not just focus on what needs to change."
The preliminary results show benefits to both students and patients. Moving forward, we would like to investigate whether similar programs exist at other schools and learn from those programs. We'd also like to conduct more rigorous post-program surveys to increase the study's validity. And we would like to see whether this program impacts students' pursuit of primary care or patient advocacy roles in their future medical career. We'd like to thank Dr. Schmidt, our program director, and health coaches for this year's hard work.
Hi, my name is Julia Shuford, and I am a medical student at Emory. I am excited to be presenting on the work done in partnership with Women on the Rise and the co-authors listed below regarding promoting healthcare literacy for incarcerated women in Georgia. A little bit of background on the significance of our work. The incarceration of women in the U.S. has increased 600% over the recent decades. Incarcerated women who are largely from marginalized backgrounds experience disproportionate chronic disease burden, significant trauma histories, including sexual, physical, and emotional trauma, as well as limited access to reproductive health care both in and outside these facilities. Carceral healthcare is compromised by for-profit models and voluntary accreditation, prohibitive copays, and lack of transparency, as well as re-traumatization through clinical encounters that deter women in these facilities from seeking care. As of February 2025, almost 4,000 women are incarcerated in correctional facilities in Georgia, and a significant proportion of them are reproductive age. The median age is 34 years, and 58 are currently pregnant. The objectives of this project are to partner with Women on the Rise, abbreviated WOR, a community-based organization founded in Georgia. 2 is to enhance healthcare literacy for incarcerated women in Georgia. And 3, to deliver accessible, trauma-informed, quality health education via a monthly newsletter. Women on the Rise is led by Black women who are impacted by the legal system. Their mission statement is to envision a world where women, families, and communities truly thrive, not just survive. Together, they will educate, heal, and empower themselves, one another, and communities as we demand justice and dignity. The interventions that we have done in partnership with WOR is incorporating a health section within their monthly newsletter that is sent inside to women's prisons in Georgia. To the right of the screen, you will see an example of this health section that was published in August of 2024. The topics we have highlighted thus far are abnormal uterine bleeding, fibroids, polycystic ovarian syndrome, PCOS, as well as HPV testing and pap smears as part of cervical cancer prevention. And the goals of these sections are to focus on recognizing the symptoms, understanding the treatment options and what that may look like, as well as promoting preventative health care. We've received positive feedback and reported increased engagement with healthcare resources based on these newsletter Health Corner interventions, and there are plans underway to conduct impact evaluation, including sending surveys regarding just the understanding of health, what the health of these people was like before and during incarceration, and what they would like to hear more about in terms of women's health. And we want to expand topics based on what they feel is most important to them. This also is important to strengthen care and continuity post-release through these community partnerships so that these women are able to access and continue health care once they are released from facilities. Our goal is to promote reproductive justice, especially in this turmoil of the legislation since Dobbs was overturned in 2022. So especially being able to advocate for this vulnerable population and empower incarcerated women with critical health knowledge. It's just a little bit that we can do to challenge the systemic barriers in ability to access quality health care during incarceration and on re-entry. And we are very grateful to our community partners at Women on the Rise for this opportunity to partner with them, and we look forward to continuing our work with them.
Go.
Hey everybody, thank you for having us here at Health Equity Day. My name is Kenny Okafor, and I'm joined by my colleagues and friends Ekene Agu and Kay Tori. We're medical students from Emory School of Medicine, and we did our project on fostering social connectedness among adults in a long-term care facility, and we did this project over at Bud Terrace at Wesley Woods. So you may ask, what exactly is Bud Terrace? It's a skilled nursing facility that offers both short-term care following hospital admissions and long-term care for adults requiring assistance with their daily living. You would think it's a long-term care facility, so you would think Bud Terrace mostly serves the population of older adults, but they actually have many younger residents under the age of 55 that also live there for support following strokes, injuries, and chronic illnesses. So you can think of the year we spent there in two different halves, the immersion phase and the initiative phase. So the immersion phase, we spent the entire fall visiting and getting to know residents. And, through our conversations with them, we kind of noticed that there was a big theme and that many of the bed-bound younger residents felt lonely and isolated from co-residents. They were also less engaged with group programs that Bud Terrace tried to put on for them. And Bud Terrace staff also expressed this concern due to seeing increased trends of depression and anxiety among residents in this younger population. These observations inspired our project focus, which was to promote connection and engagement for Bud Terrace residents under the age of 55. I'm going to pass it off to Kay to talk about the initiative phase in the spring.
Great. So thinking about this goal in mind, we started off the semester by holding a focus group with 9 residents to kind of understand their lived experiences and gather ideas for the program. They helped us come up with a slate of 5 great activities, which we held once a month over the course of the spring semester. So we held an ice cream social event, a paint and sip. We hosted a trivia day, a spa day, and then we said goodbye with a goodbye picnic. And you can see some photos here from the event, each of them shown with consent from the residents. You can see we really did have a lot of fun, and we got to connect many residents with each other, which was great.
So at our last session, we gathered some qualitative feedback from the residents and we got some quotes from them. And one of them specifically said, I usually sit in my room and play my own games on my tablet. It was nice to play games with other people. And this was quite nice to hear because it showed that the extent of social isolation and also further drives home the value of social connectedness and our work with them because many of them, one thing to note is that many of the majority of our residents, this was their only social outing. Most of them only really left their room for medical appointments. And we found several of them had lived down the hall for each other for years and hadn't even met each other before. Um, some of the challenges we faced were that our main challenge was participation with an average of 5 residents attending each event. Um, our focus our focus group also consisted of individuals who already felt a diminished sense of connectedness with the other residents, which may have influenced their willingness to attend. So, some opportunities for growth could be if the next group of medical students who attend Bud Tears will use their art framework to build the program further, continuing to listen to the residents to best engage and support them. There's also opportunity to gather more qualitative feedback and quantitative feedback from residents regarding social connection and well-being, and basically identify the perceived needs of the community by listening to the residents and fulfilling them in whichever way is possible. Thank you so much for listening to us, and we appreciate this opportunity.
Hi, everyone. My name is Mihir Chaudhary, and I'm presenting The Patient as Criminal, Carceral Logics of Trauma Centers, co-authored with Mark Spencer. While hospitals are often seen as universal places of healing, in reality, the police and carceral logics of society follow patients into clinical spaces and continue to reproduce their criminalization. EDC, over 5,000 people a day suffering violent injury, with Black Americans sustaining twice the rate of violent injury as white Americans. Trauma center EDs are a key site of police and carceral intervention because of this high rate of violent injury that arrives there. Cars Patients under custody are entitled to HIPAA and EMTALA rights, and survey data suggests that most providers routinely violate the rights of patients under custody, thus raising the importance of this topic. I want to really highlight how patients are criminalized using a case example of a 15-year-old Black youth who had the history of many prior psychiatric diagnoses throughout his life, multiple foster home placements that he had bounced around through the system, who presented to our trauma center after a high-speed MBC. He was admitted under the continuous supervision of 2 DFCS officers, and he was cuffed with metal handcuffs both in his legs and his hands. This young person was severely traumatized, afraid in the hospital, stating how he felt like everyone was trying to kill him. And these carceral kind of tools and the presence of officers reinforced his fragile and vulnerable position. Specifically, you can see here in the EMR, multiple safety alerts were tagged to his Epic profile with safety alerts saying that he posed a violent risk, that he was hostile, verbally aggressive, automatically creating a bias, which was then reproduced, as you can see in the other side with the Epic chat. Social workers and case managers basically stating that the patient required his level of confinement and supervision by 2 DFCS officers because he was a prior flight risk. This kind of default recriminalization of patients is not uncommon. It happens frequently in the hospital and is reinforced by such labeling and such interdisciplinary communication. It's often the result of structural blindness, the inability to contextualize broader root causes of patient incarceration. So, as far as solutions, there are many organizations doing amazing work currently to address some of these practices and some of the omissions within our care providers in terms of respecting the healthcare rights and privacy rights of these patients. We have organizations such as Scoop here within the Atlanta and Emory system, the Stop Criminalization of Our Patients, putting forth guides for how providers can respect the rights of those who are in custody. Beyond Do No Harm, or BDNH, is a national organization that collects resources, puts on webinars, and provides education to providers who are interested in reducing the effect of the carceral state on patients. And HCW for Abolition, Healthcare Workers for Abolition, is an example of a kind of social and political movement within the UCSF San Francisco General Hospital, seeking for the ultimate kind of removal of uh, carceral and police officers from the healthcare spaces. Thank you for your time, and I look forward to questions.
Hello, my name is Rafe, and I am one of the student coordinators at the Mosaic Mental Health Clinic, here to present our project on identifying barriers and facilitators to psychiatrist engagement at a student-run mental health clinic. The Mosaic Mental Health Clinic in Clarkston, Georgia, is a student-run mental health clinic run primarily by medical students at the Emory University School of Medicine. It remains the only clinic at Emory that focuses specifically on treating or managing the mental health needs of patients. Although the clinic has successfully been operational since 2017, we have faced challenges in physician recruitment. To that end, this project sought to help us manage that problem by exploring factors that might influence the decision of psychiatrists to volunteer at the clinic. In doing so, we hope to gain insights that will help us develop more informed and targeted strategies for physician recruitment and retention. To gather the data, we emailed an electronic survey to psychiatrists at Emory University, and so far have received a total of 14 responses, although the survey does still remain open. 9 of those responses came from residents and 5 came from attendings. The majority, that is 9 out of 14, of people who responded had not heard of the clinic before, and only 1 respondent had previously volunteered at the clinic. Responses to the Likert scale questions were summarized in figures 1 and 2 below. Overall, the most important insights gained from these Likert scale questions were that in terms of barriers to volunteering at the clinic, survey respondents most frequently cited personal obligations as the #1 barrier, followed by a need for rest after the work week, as the clinic is on a Saturday, and also work conflicts, which also sometimes conflict with or interfere with the ability of these physicians to volunteer at the clinic. A majority did state that volunteering was important for them. However, few felt that they currently had time to volunteer, and no survey respondents reported being personally invited to come volunteer at the clinic. Overall, residents were more likely than attendings to express an interest in volunteering at the clinic, and also generally sought more information about the clinic in the free response questions in the survey. Overall, at this point, these findings suggest that to boost weekend clinic participation, the coordinators have to find ways to make volunteering at the clinic easier and more accessible for interested parties. This can involve potentially adopting a telehealth model or offering multiple shifts or shorter days volunteering at the clinic for some providers that might be interested. We also need to or can find ways to incorporate residents into the clinic, as we haven't done that previously, and many did express interest. And we can also identify targeted outreach to identify specific psychiatrists that may be interested in volunteering with us. Thank you.